Hello. Hi, everybody. Welcome and thank you for joining us. While we're giving people time to just kind of tune in, if you guys want to go ahead and drop in the chat where you guys are from and where you're listening from, and that way we can see where everyone is coming in. I did want to go over just a couple housekeeping things. Um, I'm going to drop a link about half to three-fourths of the way through the webinar. You guys will want to fill that out if you need your CE certificate. You will have to fill it out and then you'll get a blank certificate, and that way you can fill that out manually. Um, in addition to that, if you guys have any questions or anything, go ahead and drop them in the Q&A, and we will save them for the end for Dr. White to go over. Feel free to chat in the chat, but we'll leave any questions for the Q&A. I think that is everything for me, so I'm going to go ahead and pass it off to Adrian from Zarasyl.
Good evening, everybody, and thank you very much for joining us this evening. Tonight, we're honoured to welcome Dr. Stephen D. White, Distinguished Professor Emeritus from the University of California, Davis School of Veterinary Medicine. Dr. White is a diplomat of the American College of Veterinary Dermatology and has dedicated decades to advancing the field of veterinary dermatology through clinical practice, teaching, and research. Throughout his career, he has received numerous prestigious honors, including the American College of Veterinary Dermatology Award of Excellence, the Frank Kral Award, and the AVMA Clinical Research Award. Dr. White has authored an extensive body of dermatology research spanning companion animals, equine medicine, exotic species, and livestock. We're very excited to have him with us here this evening to share his expertise on updates and treatments of equine Pastern dermatitis. Please join me in welcoming Dr. Stephen White. Thank you, Dr. White.
Thank you, Adrian, for that really nice introduction. I appreciate it, and I think your accent makes it sound even more official than I usually hear, so I appreciate it very much. And so thanks to the Adrian and the whole Zarasyl team for inviting me to give this talk. It's one of my favorite talks because it oftentimes is challenging for the veterinarian to deal with this in equine. And by the way, when I say equine, usually it means horses, but it can also mean mules and donkeys. And I have a couple of examples of those species as well. So what I want to do is to go through primarily at the beginning diseases or conditions that can be very frustrating, and it's important to try to recognize them. Some of these are classic, but I always say something is only classic if you've seen it at least once before. And this is one, this leukocytoclastic vasculitis. Leukocytoclastic just means that the white blood cells are in the walls of the blood vessels and they're dying or they're falling apart in there. And this can be seen in any horse breed. At University of California, Davis, which may not be reflective of your species mix. It's primarily was seen in quarter horses and thoroughbreds, mixed breeds, paints and pintos, and Arabians. Compared to the hospital population, paints and pintos were more than expected, and for reasons we're not quite sure, thoroughbreds less than expected. So how does this present? This is a good example. We have lesions confined primarily, but not exclusively, to the white areas, in this case of the front legs. I would say that we can see this in horses that are well pigmented. They don't necessarily have to be white in color. But this is interesting case because when you first look at it, one could think maybe it's photosensitization. We'll talk about photosensitization in just a minute, but this is more of a photoaggravated vasculitis. In other words, this vasculitis exists already without the ingestion of any photodynamic agent. So this is not a horse, for example, that has liver disease. This is not a horse that's ingesting in a pasture full of, let's say, St. John's wort, for example, or wild carrot. Now, I can't tell you that just by looking at this. And many times, the first thing I will do in a case like this is take a piece of clear Scotch tape, tape the area, put it on a microscope slide, put a little bit of blue dye from a Diff Quick dye kit, and then look at it. I usually look at it under low power, the lowest power, and then I just go right to the oil immersion. Do I see lots of bacteria? Do I see lots of yeast? If that's the case, then I'm probably going to use a topical antibacterial agent, and we'll talk about that a little bit later. But if I don't see anything like that, the next step, I think, is to talk to the owner about what's in their pasture or what the horse is being fed, and also see if the horse is off feed or is looking poorly, in which case I would run liver values. So that's kind of a stepwise approach that I will take, and we'll talk about any modification of that as we go on. Now, this is a more severe case, and as you can see in this thoroughbred, it's not just only affecting the white areas, it's also affecting the black areas. And there are two things I think to point out here. First of all, note how most of these are somewhat circular in conformation, as well as being ulcerated. Now, why are they circular? Well, the reason is that if you think about how the blood is supplied to the skin, it's in what's called an arborization or a tree. So here what's happening is if you will, the trunk of the tree is being affected adversely. It's the vasculitis. It's being inflamed. It can't function so well. And so anything that's downstream, that is, as it goes from, let's say, the deep dermis to the superficial dermis and trying to supply the epidermis, it's not working. It can't get the red blood cells there because the vascular tree is so compromised. Now, circular areas that are not ulcerated, and that makes me think more of a follicle problem, like a bacterial infection with staph or a dermatophyte infection with trichophyton, for example. But when it's ulcerated like this, one of the first things I think about is, could this be a vasculitis? Now, how do we diagnose a vasculitis? Well, unfortunately, the only way that is relatively available to most practitioners is to go ahead and take a biopsy. If you're going to take a biopsy, of course, you're going to deaden the nerves in the lower limb in this case. And you want to take two different kinds of biopsies. One is you want to take it where the skin is still intact, just on the border. And the other is to take it in the middle of the process, because finding vasculitis for the pathologist is not very easy. So you want to see where it is at the beginning, and you want to see where it is in the middle. Now, some people I usually will take just a biopsy punch, a 6 millimeter biopsy punch, and punch those two places, right on the edge, and then again in the middle. Other people will do a wedge biopsy. They'll start at the edge and progress into the middle, and then come back like a piece of pie. And there's nothing wrong with doing that. I find that those are a little harder to heal because, as you can imagine, in that ulcerative area, it doesn't hold the suture quite as well as one would like. But either of those processes are okay. Ideally, what you want to do is, whether you're taking the pie shape or if you're taking a biopsy punch, ideally what you want to do is cut them in half and take half and put it in formalin, the other half put in whatever transport media your laboratory wants you to use for bacterial and fungal cultures. Because depending on where in the world you're practicing, this could be either a severe bacterial culture like, bacterial organism like Corynebacterium, pseudotuberculosis, or it could be a pythium, pythiosis. Again, that's somewhat geographically dependent. We'll talk about both of those a little bit later. So when you see vasculitis, what is there an underlying cause, or what is the underlying disease? Most of the time, as I said before, it's photoaggravated vasculitis with dermatitis. It has a tendency to be in the white or the poorly haired areas, but as we saw in this last case, it can also be in the pigmented areas as well. Purpura hemorrhagica, which I'm not going to go into any detail on because I think most practicing equine veterinarians are familiar with that, is essentially a necrotizing vasculitis. And I don't have, when we did our retrospective study, we didn't have that many because most of those are seen in the field and aren't biopsied necessarily, just treated as because of how they look. So, but we can also see this with drug reactions. Acepromazine, detomidine, these are common anesthetic agents. Trimethoprim sulfa, mycobacterial immune modulators, usually from the mycobacterial wall. Again, depending upon where you're practicing in the world, these may or may not be available. A West Nile virus vaccine, penicillin, and then toludronate. And all of these in our retrospective study were responsible for occasionally the vasculitis. But again, the vast majority were this photoaggravated vasculitis. And I'm not going to make you pathologists, especially those of you who are either before or after dinner. It's not fair, but I believe you can see my arrowhead. But this blood vessel and the one next to it and the one next to that just don't look good with all this what's called fibrinoid deposition. These are sick blood vessels. And so in this case, it's a cell-poor vasculitis. There are different vasculitides. Histologically, that's not really relevant at this point for our purposes as clinicians. But it is important to realize that it's not easy for the pathologist to find. And if you really think that you have a vasculitis and the report comes back as some sort of general, deep dermatitis, it's important to ask them to please go through and do a step section. Some people call it bread loafing, looking to see if you can find the if the pathologist can find the vasculitis. So what can we do to treat? Well, for severe cases that need steroids, triamcinolone spray. Genesis is made by Virbac. And by the way, I don't get a kickback from these companies. The triamcinolone spray is available, and corticosteroid sprays are available from other countries. What I like to use is pentoxifylline. We'll talk about pentoxifylline in a minute. Pentoxifylline is a methylxanthine derivative, and some of you may already be familiar with this. What it is supposed to be doing is it makes red blood cells more pliable so they can get down through damaged vascular tree. And well tolerated by most horses. Dosage is 8 milligrams per kilogram twice a day. The only horse, it is related to caffeine, but I only had one horse act like she drank too much coffee, and that was because the owner had doubled the dose unwittingly. But 8 milligrams per kilogram twice a day. It doesn't take effect right away. It's not like corticosteroids. It usually takes around a month to see improvement. Trimethoprim sulfa, the trimethoprim sulfas, I think, are the workhorse of secondary bacterial infection treatment. I especially use this in the warm weather. I recommend it in the warm weather where these lesions tend to get more secondarily infective. Or if I'm using dexamethasone or prednisolone, I think most of you know prednisolone is better better absorbed and metabolized by the horse than just prednisone. And as to dexamethasone, I usually give this orally. It's been shown that around 60%, that the dexamethasone given orally is at a point of about 60% of, compared to if you were giving it by injection. And then tacrolimus ointment we'll talk about in just a minute as well. So here are some of the corticosteroids that I've used in the past, mainly Genesis or Trisclor-4. In the United States, we don't have Cortivance, but you have it in Canada and in Europe. Again, I don't have any real preference one way or the other. I'm just more familiar with the Genesis spray. Pentoxifylline, again, usually I go toward the lower end of the dose, 8 mg per kg on a twice-a-day basis. Now, this comes usually in tablets. Sometimes you can find it in like a granular preparation, but this is not miscible in water. If you take the granules, or especially if you take the tablets and grind them up and mix them in water, you will make something that looks a lot like paper mache. So don't do that. It doesn't have much of a bad taste, so usually grinding them up or using a mortar and pestle and mixing it with sweet feed of some sort, the horses usually take it pretty readily. I already mentioned hyperexcitability, very rare, at least in my experience. Tacrolimus is similar to cyclosporin. It's an immune suppressant. It's a little more directed at the immune system rather than the corticosteroids, which are, of course, corticosteroids suppress almost everything about the immune system. But it is, as opposed to cyclosporin, which is expensive to give to a horse, although they can absorb it. This is a topical, and it's better absorbed through the skin. In the US, it used to just be available as a trademark, but now it's a generic tacrolimus ointment. It is important that if you're going to use this or have the owners use it, make sure they wear gloves. You don't want to absorb this stuff or have the owners absorb it. So just to show you here the initial presentation, which we already saw in that thoroughbred gelding, and then how much better it looks 2 months after starting the trimethoprim sulfa, a tapering dose of prednisolone, and the pentoxifylline, and the topical triamcinolone spray, the Genesis. And sometimes I will start with all of these, depending upon the season, depending upon if I feel it's secondarily infected. And what I try to do is taper back slowly on everything so that the horse can be maintained just on the topical. So where does Zarasyl fit in with this? This is, as most of you know by now, this is kind of a silica-based barrier function product. There's no steroids, there's no antibiotics. And yet it seems to be able to induce or to reduce the inflammation in a lesion. It promotes wound healing, and it has some antimicrobial power effect. And so I put it here. I will mention it later on in our talk, but just about any time that I mention a topical, you can turn to Zarasyl. And it probably would make you more favorably inclined than just hearing it from a dermatologist if you just Google Zarasyl and go to some of the unsolicited comments by horse owners, but especially by veterinarians. But here I'm going to show you, this was severe vasculitis, just in one area. It was secondarily infected, and it looks awful there on the left. And on the right, just about a week after, just applying the Zarasyl, nothing else. And you can see how what's interesting here is not only does it look a lot better, it doesn't look infected anymore, and it's starting to granulate in. So I just want to mention briefly photosensitivity, because photosensitivity is different from that photoaggravated vasculitis. In theory, a horse with photoaggravated vasculitis, you put it in a box stall so it wouldn't have any exposure to the sunlight, and it would still have problems. Whereas with photosensitivity, you need that ultraviolet light, UVA actually. You need a photodynamic agent that's usually an ingested substance or liver failure, and we'll talk about that in just a minute. And then you need the cutaneous absorption of the UV radiation, which means that you need a non-pigmented or lightly pigmented, lightly haired areas. Clinical signs, erythema, vesicle formation, crust, and sloughing. And vesicle formation is oftentimes rather transient in the horse. I don't see blisters per se very often in horses. Now, that may be a function of having worked at the university, and sometimes these blisters happen very early in the process. So by the time the horse is brought in to see the university, we may not see the actual vesicles, but crust and sloughing. So there are two types of, actually, there's three types of photosensitivity, but we're just going to talk about type 1 and type 3 because those are the ones that affect the horse. Type 2 affects like Corriedale lambs with a congenital problem with their liver. So type 1 is a primary photosensitization because they're ingesting a photodynamic agent, whether it's St. John's wort. And if you were wondering, how did a plant get that name? Wort is an old English name for flower, and it blooms on St. John's Day, or people thought it bloomed on St. John's Day, which is in June. Now, whether it really did or not, because the English calendar system changed during, I think, the 1600s or 1700s, and you can look that up. I'm not going to go into that. So buckwheat, bishop's weed, wild carrot, and then initially phenothiazine and phenothiazine derivatives have been implicated. That seems to be happening a whole lot less these days. It's more an ingestion. I would just say also when I was in Colorado, occasionally, some years, the alfalfa had some sort of photodynamic agent in it that caused a primary photosensitization. So there's the St. John's wort, there's buckwheat, and here's what happens with this is from Australia, and you can see here it's very specifically hitting the white areas. And that's another way that photosensitivity is a bit different than the photoaggravated vasculitis, because as we saw, photoaggravated vasculitis can hit pigmented areas as well. Photosensitivity has to be in either very lightly haired areas or white areas, as we can see in this horse, on the white areas on the face as well as on the legs. And then photosensitivity type 3, which is more difficult to control. This is acquired through eating hepatotoxic plants, common ground cell and salvation jane. They have pyrrolizidine alkaloids, and alsike clover, where we don't really know the toxin as of yet. At least when I looked online yesterday, nobody had the toxin. Alsike clover, salvation jane gets its name because oftentimes it was the only thing that the cattle or the horses could eat that was growing in a pasture, and then common ground cell. So those are the plants that will hurt the liver. Now, why does that matter? And some of you may remember this, but ingested chlorophyll changes in the gut to phytoerythrin. And phytoerythrin is absorbed into the portal circulation, into the liver, and then the liver removes it and excretes it in the bile. So that's great. The problem is when the liver isn't working, then the phytoerythrin is not removed in the liver, and as the liver function goes down, the phytoerythrin in the bloodstream goes up, it percolates into the dermis and acts as a photoactive agent, absorbing the sunlight energy and then passing it on to the cells that are around it and causing damage. Interestingly, chlorophyll looks a lot like hemoglobin when you look at the chemical formula. And just as hemoglobin, if it's not processed correctly, can also cause photosensitivity. An example in large animals, of course, is the so-called pink tooth in the Holstein cattle. So this is an example of a horse who, once again, just has it in the white areas. You can see how it just doesn't lap into the brown areas, but this animal had been ingesting, I think it was fiddleneck, the owner did not realize it was in the hay that she was feeding this horse, and it caused liver damage. So how do we treat it? Well, avoiding ingestion of photodynamic agents, of course, for type 1, corticosteroids to treat the inflammation for short term. And then for type 3, stop ingestion of a hepatotoxin, liver support. There seems to be anecdotal reports that alsike clover toxicity may have a better prognosis. So we had mentioned about the vasculitis, that's sometimes overlooked or not thought about enough when we're dealing with problems for Pastern dermatitis or scratches or whatever we're going to call it. So this is another one that you may not be familiar with. It is primarily, or to my knowledge, exclusively seen in draft breeds, chronic progressive lymphedema, although there may be a case in a donkey. Chronic progressive lymphedema, or CPL, Belgians, where it was first noted, Shires, Frisians, Clydesdales, Gypsy Vanners. Initially, it looks like really bad Pastern pyoderma or even choreoptic mange. And it's not unusual to see this with the horses having choreoptic mange. There's some debate about whether there's interaction, whether horses with this are more likely to have choreoptic mange, or horses that have choreoptic mange are more likely to have this, but that has not been proven. Certainly, any horse that has crust, scale, and pruritus should have superficial scrapings done for choreoptic mange. And we'll talk about that a little bit later. This CPL is seen with lower leg enlargement, with firm swelling, thick skin formation, and large firm nodules. It's not unusual to see secondary infections, generalized illness, and debilitation. The ultimate prognosis is not a good one. The etiology seems to be a defect in the elastin fibers of the lymphatics, which triggers anti-elastin antibodies as the body sees it. Again, poor response to treatment. If you have someone who's specifically trained to do pressure wraps, that will help. But as soon as you take the wraps off, unfortunately, everything comes back. This is a very good website to get information, both for yourself and for owners. There used to be one at UC Davis, but that unfortunately had the name of elephant, something like equine elephantitis, which means that your elephant is inflamed. They meant elephantiasis, but yeah, so forget it. But chronic progressive lymphoedema.com/CPL-management-protocol. So what does this look like? Here's one example. Notice the nodules. Obviously, this has been clipped. While the nodules are there, this horse is not as severe as some because they can be very, very thick. There's one rule of thumb is that if you go around to the caudal aspect of the pastern, you should be able to, in normal horse, you should be able to feel the suspensory ligament. In these horses, oftentimes there's just too much scar tissue, if you will, or fibrosis around it, and you can't. Couple of another examples from Dr. Greg Ferraro. And you can see here different levels of involvement. On the left, it's just beginning. On the right, I know some people will call this grapes, but again, on the left, that was obviously clipped up in order for us to see it. So onward. Now we get to one of my favorite diseases. I say that because I don't know why it is. It's just very interesting because it's actually a combination of different diseases that can cause this, and that's coronary band disease. And this has been seen in relation to dermatophytes, to vasculitis, to a very rare, thankfully, disease called multisystemic eosinophilic epitheliotropic disease. Eosinophils want to go into all the epithelium, so not just in the skin, but also in the salivary gland, in the biliary tract, in the liver, in the intestine. Again, not a good disease to have. Luckily, very rare, at least in this country. And even in France and Belgium, where some of the other reports have come out, it's not very common. Pemphigus foliaceus, an autoimmune disease, can sometimes affect just the coronary bands, or it will affect the coronary bands for anywhere from a couple of weeks to a couple of months and then go more generalized. Selenium toxicity, which is dependent upon the amount of selenium that the horse is ingesting, usually in an environment where there are certain plants that absorb preferentially the selenium. And then after all of these, then we have a rather poorly understood disease called coronary band dysplasia, where on biopsy, the band just looks like it's not growing the usual way. So some examples, you can see how pemphigus foliaceus up on the top left, crusting with selenium toxicosis, vasculitis. On the bottom is that rather awful disease, multisystemic eosinophilic epitheliotropic disease, which we call MEAD, and then dermatophytosis around just the coronary band. Dermatophytosis, if you have that, it's usually confined to just one leg. rather than these other conditions, which are usually affecting all four legs. So here are some examples of coronary band dysplasia. And this is from all over the world. And the upper left is from Sweden. In the top is from South America. On the right top is from Hawaii. The bottom right is from the UK. And then the other two on the left are from Austria and Germany. So all over. And this is probably one of the more severe ones that I've helped out or consulted on. And it looks like somebody has, this is a mare, and somebody has like put some sort of Play-Doh or bubble gum on it, and then it just picked up all this stuff. But this is all proliferative. And what's interesting, sad but interesting, is this mare had a filly, had a foal that was a filly that after a while developed the same thing. So how do we treat this? Well, I have not had the best success, but topical anti-seborrheic shampoos or sprays, topical corticosteroid sprays, topical tacrolimus. And this is an example where I believe that the Zarasyl would help. Now, I have to say, I haven't treated this because we don't see it that often. So I haven't treated this with Zarasyl. But it would be another place I think that it would be well worth treating because we don't know what causes this. This is usually something that occurs in adult horses. It's not something that they're born with or that comes on, within the first 6 months of life. So I'd be interested in seeing afterwards when we are doing the question and answer how many of you perhaps have seen coronary band dysplasia. Coreoptes, well, most of you are probably familiar with this parasite. There's intense pruritus with secondary crust and alopecia. Draft breeds do seem to be predisposed. Diagnosis is with superficial scrapings, but it's not always easy to find. Multiple scrapings may be needed. So this is just a couple of examples. The two on the left, we didn't really see very much until we clipped up the feathers and saw the hyperpigmentation and erythema. On the right, you can see the hyperpigmentation is there because this horse is so pruritic that it's rubbing its hair off. This donkey has the most severe case that I had ever seen of Coreoptes because it's all over. It's progressed from the pasterns and then gone up the legs, and now you can see areas of alopecia, even up as far as the mane and the shoulder area. And if we take a look at the legs, and you can see how proliferative, how folded up the skin is, and that's why some people wonder if there's a relationship, at least in some horses, with chorioptic mange and chronic progressive lymphedema. And on the right, those little white things, those aren't Coreoptes, those are maggots. Unfortunately, this donkey had lots of maggots that, because the flies are drawn to the exudate here, laying their eggs, and you have the maggots. How do I like to do skin scrapings? Well, I really like medical grade spatulas. I think they work really well. And the reason is they're dull enough that you're not going to cut, as opposed to taking an old scalpel blade. No matter how dull the scalpel blade is, they can cut. But these are just dull enough, they won't cut, but they're also just fine enough. So if you're in a situation where for some reason you want to scrape until you're down to the first capillary level, that'll work as well. So I don't get any money from Fisher Brand. This is just a flat-ended blade. You might be tempted to buy the ones that have a little spoon at the end because you think you're going to get more material. I have never been so frustrated in my life as when I tried to use one of those, because you get more material, but you can't get it out. You have to almost use another blade or something to get it out of the spoon. So just using this is what I would recommend, what I've used for years. And they're only about $12 each. The last time I looked, you can buy a whole packet. Each of them comes in a little plastic, like a little plastic sleeve. You can actually engrave them with people's initials, so that they know who's is using which one. Interesting gifts for the holidays, whatever. But you'll find that you'll use this a lot more once you have it. By the way, as far as other handy things to have, using a magnifying lens of some sort will help in many cases, because you might just see that all you're seeing is crusts or ulcers. If you take a magnifying lens and look, then all of a sudden you realize that there's a pattern, like the crusts are in circles, or the ulcers are in circles, or the rash is only affecting where the hair shafts come out. So and of course it makes for a practice builder, because everybody else looked at my horse, but you really looked at my horse when you pulled out your magnifying lens. You don't even have to buy a magnifying lens. If you have an otoscope in your practice, just take the cone off. You have a magnifying lens and a light source. So at first you'll think, oh, this is just making what I don't know a little bigger. But if you stick with it, you'll begin to see patterns that are, I think, very helpful to the clinician. So skin scraping, here's a Coreoptes. You can see them, they're mating up in the top left. On the bottom, there's a female with an egg, and here are the eggs. These are relatively large mites. I mean, you still have to go to 10 power at least. Some people can find them under 4 power, but I like to look under 10 power. But this gives you the diagnosis. So how do we treat these? Well, traditionally, it's been using ivermectin and doramectin or other avermectins. And if you've found those to be helpful, I think, great. Just keep on doing what you're doing. Remember that this mite can live off the horse for anywhere from 10 days to 3 weeks, depending upon who you read and the conditions. So if you have a lot of horses, even if some aren't showing any clinical signs, you need to treat. Another product that works very well, but is kind of smelly in those, odoriferous, in those countries that have it, lime sulfur works very well. It's important also to realize that whether you're using lime sulfur or the ivermectins, we'll talk about isoxazoline in just a minute, but ivermectin or the avermectins or lime sulfur, you're not killing the eggs. You have to repeat at least once every other week for 6 weeks. If you're using avermectin, if you're using lime sulfur, probably need to do it on a Monday, Wednesday, Friday basis for at least 2 weeks. Now, isoxazolines may be the drug of the future once a equine formulation is made, but there have been reports, for example, quite safe using oral fluorolaner, either 10 or 25 milligrams per kilogram in the horse, should get it to a level where the Coreoptes mite would be killed. And then Scheinberg et al. Showed that it is also effective against ticks that are infesting the horse. So this may be the wave of the future, just as it is to some extent in small animals. Now we come to cutaneous hydradenitis. Hydradenitis, summer sores, often called very common skin disease. So obviously a greater prevalence in temperate and tropical regions. It's aberrant cutaneous parasitism by this larva, plus a hypersensitivity reaction. These are vector dependent. The housefly and the stable fly will take these organisms. They're drawn to moisture, and what's supposed to happen is they're drawn to the moisture around the mouth. The organism, the fly, essentially leaves the larvae form of the summer sore of the Habernema around the mouth. It's swallowed, it goes down into the stomach where it completes its life cycle, and eventually these organisms release eggs into the gastrointestinal tract, etc. And I'm sure we've all seen this: Musco domestica, the housefly; Stomyxis calcitran, the stable fly. So again, the normal life cycle: the viviparous females release the larva into the feces, not the eggs, the larva. Larvae are ingested by fly maggots. The fly matures and deposits the infective larva of the Habernema on the horse. But what happens is when the flies are attracted to damaged skin or to other mucous membranes besides around the lips, then the larvae migrate into the dermis. They elicit a terrible hypersensitivity reaction, or a severe hypersensitivity reaction, and they're dead. Okay, they are dead. They cannot live in the dermis. They have to go down into the GI tract. So this is just a normal scaling of seeing the fly going to, say, around the eye, whereas it should go around the mouth, and the larva being secreted or released into the gut, and the fly larva ingesting it. And this is just a example of the kind of nodules that the adult nematodes leave in the stomach. So the sites that are oftentimes affected: the medial canthus of the eye, conjunctiva, lower extremities, because there are often wounds there, and the male genitalia. These ulcers are granular. Their ulcers have granulation to pretty yellow foci, and they're usually, as you would expect, more common in the spring, regress in the winter, and recur pretty much annually. So just some examples of lesions around the eyes, and more to the point of this this particular lecture, we can see, especially the middle picture, how proliferative that is and how ulcerative it is. And these are actually pictures from donkeys. So what are the differential diagnoses? Just regular granulation tissue, fibroblastic sarcoid, squamous cell carcinoma. If you're in an area where you could see deep fungal infections, that's one. And of course, any of the above are possibilities. How do we diagnose this? Usually by how it looks and the history. But if there's any doubt, you probably ought to do a skin biopsy, but recognize that you can see habronemaiasis secondary to squamous cell carcinoma or fibroblastic sarcoid, because those are ulcerative and the flies will be drawn to that. So you might, if you do a biopsy that's not deep enough, then you might just see the habronemaiasis and miss the fibroblastic sarcoid or the squamous cell carcinoma. So sometimes you have to use a scalpel blade. Some people will use a more of a true cut biopsy. What I like to do in these cases is take a 8mm biopsy punch a hole, take that material out, and then in the hole, go ahead and punch a 6mm so that you get down essentially 2 levels that way. So cutaneous, here we have the biopsy, and you can see all this eosinophilic mush around, and here we have the habronemaiasis, the larva. Same thing here. And this larva is dead. Okay, there's no way that ivermectin is going to have any effect here. Some people use ivermectin because they feel that it is somewhat anti-inflammatory, and I can't argue with that. But when you see something like this, I mean, I'm pretty sure that once an organism is dead, you can't kill it. And so there's no sense, I think, in most cases, using the ivermectin for this. Therapeutic goals are, of course, reduce inflammation. Corticosteroids usually will help with that, reduce size of lesion, and prevent reinfestation. So this is another place where there are a lot of testimonials on the, if you go into Google for Zarasyl, for this, because it again seems to promote wound healing. It has some antibacterial effect. It prevents flies because it's a barrier product. It prevents flies from reinfesting or reinfecting with the organisms. Again, corticosteroids will also help, but as we know with corticosteroids are the really good, really bad drug. And so if we can limit usage of that and use the Zarasyl, more power to it. And also it does seem to decrease excessive granulation tissue, which is another property. What about contact allergies? Of course, we see them all the time. Oftentimes, it's a drip pattern that we're looking at. We always want to ask what the owner has used before we get to that point. We have to sometimes have to ask that in a very collegial or congenial manner. But sometimes there's some owners who put stuff on their horse that they wouldn't put on their furniture. So it's just a question of asking what's going on. The middle one, by the way, it was just betadine. That's all it was. So just something to bear in mind with that drip pattern. Treatments, interestingly enough, if it's just a small area, of course, we can use Zarasyl. But pentoxifylline has been shown to be quite helpful with contact allergy and contact irritant cases. So I will often turn to that first if I don't think that it's going to be able to be controlled just with a topical. Staph pyoderma, we see this from time to time. How do I know that the one on the left, the case on the left, isn't either photosensitization or photoaggravated vasculitis? And I don't, but when I did my my Scotch tape test or cytology test, lots of neutrophils, lots of cocci. So in that case, I just actually only used a topical antibacterial. We'll talk about that in just a minute. Another case that looks, well, it looks like an oval, but it's essentially a circular lesion. So how can you tell the difference between a dermatophyte versus a pyoderma? Because they both are hair follicle infections, and they spread out, so they can, either one of them can cause the circular alopecia. Well, you can't really tell the difference, and I think that's one of the reasons why oftentimes we think that these are dermatophytes, but they're really pyodermas. I think that it's just something that we need to bear in mind. The best way is, of course, pluck hairs, send them off to a laboratory to see if there's fungi, but and you don't see on just simple Scotch tape tests, you don't see dermatophytes, but sometimes plucking hairs from the margin of the circles, if you put it underneath the microscope, again, using either the blue dye from a Diff Quick or another similar type product, sometimes you can see the hyphae, but that's definitely an acquired skill. It's not easy. So what can we use to treat as antibacterials? If it's just a small area, I like either, aside from Zarasyl, I like muracin or mupirocin. This is a veterinary product. It's on the human side too, but it costs about 8 times as much. So I find muracin's very good. Like Zarasyl, it doesn't stink, or stain. So Sylvadene cream, of course, also can be used. Large areas, you can use the Vetricin VF. I'm not very impressed with Vetricin for fungi, but I think it works reasonably well for bacteria. And then Trischlor 4, which has the advantage, as does Zarasyl, of having a horse on the label. And that does make a difference to people when you have a topical product. It's nice to see a horse if you're on the label, if you're giving it for use in the horse. Corynebacterium pseudotuberculosis. This is a problem. It can be both internal, and this mammoth donkey had internal abscess. You can tell by how thin the donkey looks, as well as these bleeding, draining tracts on all 4 legs. Corynebacterium pseudotuberculosis is diagnosed by biopsy and culture. Sometimes by cytology or sending it off to a lab that looks at cytology a lot. And then in this particular case, this donkey was put on antibiotics based on the culture and sensitivity, and did very well, but needed antibiotics for a couple of months. Dermatophilos, or dermatophilosis, caused by Dermatophilos congolensis, can certainly cause lesions on the distal extremities. It needs 3 things to make an infection. It needs moisture, and it needs trauma, whether that's high-powered hoses turned on the horse by mistake because they were trying to clean out the stall, or tick bites, or other arthropod bites. So moisture, trauma, and a animal in the environment that is a carrier. And sometimes that can just be crust that's fallen on the ground. Cytology shows these so-called railroad track cocci. Treatments, usually these respond well to just topical antifungals. I like a combination of topical antibacterials. I like a combination of chlorhexidine with any of the azoles. Miconazole is my favorite. Miconazole, though it is an antifungal, it also has antibacterial properties. We mentioned dermatophytes, and I would say, again, oftentimes these are well controlled with just topical agents against the dermatophyte, such as a combination of chlorhexidine and miconazole. Sporotrichosis is a fungal organism that is worldwide and can oftentimes affect the distal extremities and then work its way up and eventually infect and invade the lymphatics, leading to this ulceration. It's a severe case here. Donkeys seem to get sporotrichosis not only on the distal extremities, but in the inguinal area. And this is a sad case where this Jenny had the problem and then became involved with dispute between owners and was never treated. And here's the same animal 4 years later. Looking at something like this in a wide area on a horse or a donkey or a llama, the other big differential I would have is a squamous cell carcinoma or mammary gland adenocarcinoma. Equine sporotrichosis, I'm not going to go into all this, but one thing I would say is if you have a case, go into the literature or send me an email, sdwhite@ucdavis.edu. I can send you the references. But the thing that works the best is organic iodide powders work well. You can sometimes see adverse reactions, iodinism, especially scaling alopecia, and a discharge from the eyes or the nose. It's not that common, but it does happen. And when it does, you have to discontinue for a week and then resume at 3/4 of a dose. You can also give this concurrently with fluconazole, which I did do in a donkey and in a horse with perhaps more rapid control of the disease. This, by the way, is an is a Przewalski horse, and you can see that nodule on the right side of its face. That is sporothrix. This is a horse in the Denver Zoo. Neoplasia can certainly affect the pastern, the lower limb. I am not going to go into squamous cell carcinoma or equine sarcoid because that's a whole other lecture or lecture and a half. But just to be aware of these because they can, again, become secondarily infected with habronema. Proud flesh. There are testimonials about Zarasyl and its use in proud flesh. It is, I think, still somewhat of a puzzle, at least to me, as to why some horses get all sorts of wounds and never get it, and other ones get proud flesh seemingly at the drop of a hat. And then we come to Pythium. Pythium insidiosum, or sometimes called swamp cancer, seen primarily in the southeastern United States along the Gulf Coast. But this picture here is from a horse that's never been out of Davis, California. But it did stand in brackish water. So this organism, which has been seen all around all around the world, in tropical environments like Indonesia and Malaysia and in Africa, it is a difficult organism to treat. Interestingly enough, in this donkey, the largest lesion was removed and the other ones all resolved, which I find obviously what happened is some sort of antibody reaction occurred when the surgeon took the lesion out so that the antibodies recognized the organism and it resolved. It's not something that happens very often, but I was impressed, at least in this particular case. So treatment, this usually has a poor prognosis. There's surgical debulking of lesions, certainly. There is an immunotherapeutic vaccine, which you can order from Pan American Laboratories. Again, I don't have any affiliation with them. And recently, a combination, this has been done both in some parts of the US as well as in Australia. There's phenoxym, an agricultural antifungal that's been combined with prednisolone, terbinafine, and minocycline, has been reported to use successfully in treating dogs with pitheosis, and just anecdotally in horses, but more and more people are using this. Now, why does this work in a treatment in an organism? Pythium insidiosum is not a fungus. It's what's called an oomycete. Oomycetes are probably most famous for having caused the potato famine in Ireland about 175 years ago. But in any event, this does seem to be hopeful and on the horizon. And with that, I'll end. I'll just say if you're really interested in horses, there will be a horse or equine session if you're doing mixed practice. There'll be lots of stuff for other animals as well at the World Congress of Veterinary Dermatology. This is the 11th one. It's every 4 years. It's in Seville, Spain, which is a wonderful vacation tourist spot as well. And so mark your calendars. If you're employed but not the boss, then it might be time to ask your boss for time off well in advance. And with that, I thank you, and I am open to any questions.
Thanks, Dr. White. It looks like we did have one question. So Haley asked, she wanted to know your thoughts on fovea for cutaneous habronomiasis.
Well, I have a short answer and a long answer. Okay, so the short answer is I haven't used it. Um, the somewhat longer answer is I did see a report that was submitted. I don't know if it was accepted um, by a journal, and I honestly can't remember the journal. But in that report, they seem to have some success. The problem with that particular paper is that in addition to using fovea, they were also using corticosteroids and various topicals. So I wouldn't be surprised if fovea helped, or at least was an ancillary help, because it does seem to function well as an ancillary treatment in a number of different skin lesions. But that's about the best I can do with that answer.
Okay, thank you. I wanted to remind everyone that you can, if you want to learn more, you can book a call with the Zarasyl team, and they can go over any questions or anything for that. Anything else from you, Adrienne?
No, I'd just like to thank Dr. White, very informative, and thanks everybody for joining. I hope you uh, got learned a lot, and I am open to having conversations with anybody about Zarasyl in due course. So please go ahead and book some time, and I look forward to hearing from you all.
Thanks so much, guys.
Thank you. Thank you, Dr.
Thank
White.
you. Thank you, Kaylee.
Bye-bye.
Bye.